Okay, so I did want to highlight, why can I not, what is it saying? It's giving me trouble with my recording of, you cannot minimize Zoom when you are recording this meeting. Okay, all right, whatever. Okay. So I know what I'll do. I'll share the screen and then it won't have my face be huge. Okay, so I did want to just highlight a few things here. So next week, week 12, we have the panel proficiency in lab. And so basically you're just gonna, when you're in your group of 4 at the table, I'll just pair up 2 of you and you'll go in and you'll run through that whole thing that Teresa led you guys through, but without any help. So there's this, there's this sheet here. I put it in. Oh, it's way at the bottom. No, where is it? Here it is. I'll move it up. But I'll leave it there because it says other resources. But this panoramic instructions, I printed it out and gave you guys a handout of that. But if you don't know where it is, you lost it, then that's where you can find another one, because you need to be able to say to your partner, today we're taking a pano. This is going to show us all of your teeth at once. You know, you don't have to talk about like the details of why we take panos, but just be able to like say it to your patient. So they're like, what's happening? So you can tell them what's going on. And then you have to be able to remember to put on the lead apron, tell them to remove jewelry or make sure they don't have anything in their mouth or on their head or on their necks. It's metal that'll show up. You have to situate them into the machine, make sure all their planes are in the right place. That they're hanging on, that you've told them to step forward so that the spine gets out of the image. All of these things you need to just remember to do. This needs to just, without Teresa or myself, whoever's in there, but probably Teresa prompting you. And then you'll give them the final instructions: tongue on the mouth, hold still, swallow, it goes around your head 15, 20 seconds. That whole spiel, you have to do all of that without prompting. And if you do miss something, it's fine. You just miss a point or so. And so, however many points you have to pass by 75. So if you don't do it perfect, you can still pass, but you want to shoot for getting all those steps in. And then you'll press the button. It'll be on test mode, goes around their head. And then you walk them out, take off their apron. And then there's going to be a pano that you're just going to critique. So it'll say things like, is there a gentle smile line? You mark either yes or no. Are there, did it meet all the criteria? Are the apices cut off? Or, whatever. It'll ask you some questions and you have to say either that criteria has been met or it has not been met. So it's like there's an error. If the criteria has not been met, there's an error. So then you just critique a pano and then that's the proficiency. So it's pretty straightforward as long as you remember all those steps. And so just you can study that there in case you need a refresher. And on Monday, we were giving everyone the opportunity to go in and practice on each other. And so we'll do that for the Wednesday group as well. The panel room will be open and you can just go in there after, because everyone's doing great. Not to set anyone get nervous for Wednesday group, but everyone on Monday did great with the time, Dexter. So you should feel confident going in. You guys are doing excellent job taking x-rays, excellent job critiquing. I'm really excited about how well you all are coming along. And of course, there's a variation in experience, but even those of you with no experience are doing such a good job. I'm really, really, really excited because I think you guys are going to show me really good next year and next semester, which I won't take credit for it, but it makes me excited because I'm like, oh, they're doing good. So I'm really happy about that. But I do want you guys to make sure you review stuff that we haven't looked at for a little while. So there's that. And then, and then in the rooms, we're going to do, I just wanted to bring your attention to this. We're going to take bite wings with tabs. So no rings at all, just the tabs. And then we're going to try just occlusal images, which is super easy. You're just going to put it in the Dexter's mouth like this and take a maxillary and a mandibular. But it's important to just try it out because you will likely do it on kids. So that's really the only time you'll probably take occlusal films, but you will certainly probably do it on kids in your career. So we'll play with that a little bit, and then really, really think about how you're doing with things like getting back far enough, thinking about place centering the second molar. If you're struggling at all and you haven't really conceptualized fully about centering the second molar, take the opportunity to practice that, or the Q-tip opening contacts. If you're still like, it's like luck that you get it done half the time, really try to hone that skill so that you're really consistent with it, because that'll be a big, once you're into the radiographs on live patients, that'll be a big thing that they'll notice. If you're closing contacts on patients, they're going to notice that. So make sure you really grasp that concept of utilizing the Q-tip and how it's working out. So that'll be opportunity. And like buddy up with someone. If you hate your Dexter because it's that horrible one in room 267, buddy up with someone and just take the hour and work on a better Dexter. Like, it's a little free, but don't just kind of be like, I don't need to do anything, because you're there to have time to actually work and perfect this stuff so that you can actually, improve even more. And I know Dexters are not real humans, but you can work on some of these skill sets. Okay, so that's all I wanted to say about that. So I'm going to bring this guy over here, and then I'm going to pull up, we're going to finish the Caries interpretation. I'm so excited that we don't have like a quiz or anything, so we can just go, I know, team, so we can just go right into this. Okay, stop share. Oh, so sorry, I ended too fast. Thank you for saying that. So after that session, so on Monday's group, after that lab is done, just bring your XCPs into sterile and bag them up. You just have, and we'll just make sure, Teresa and I will either start a load, or the next day I'll go in and make sure they're getting through sterile. But yes, so if you're on Monday's group, bag them up on Monday, and if you're Wednesdays, bag them up so that they're sterile on week 13, because week 13, I want you guys to pair up and place them on each other, but not just place them on each other, due to get them seated, your patient bite, and bring the BID over. And last semester, the one thing that I kind of learned from it is that, for one, they're uncomfortable. So people kind of minimized how long they kept it in their partner's mouth, their patient's mouth, their partner's mouth. And so they didn't bring the BID over and work out all those kinks, of the real life kinks of your patient being uncomfortable and actually getting it in your patient's mouth. Like, it's the time to do that. And so people kind of were in and out real fast. And so I told myself, I wanted to make sure that everyone took that opportunity to like place them, bring the BID, and try and work through some of those difficult real life situations. So you'll do on one person the full mouth, and then you guys will switch. So we'll have to turn over the rooms and things like that. It may mean that we're not actually, I still have to kind of figure out the schedule a little bit, and it may mean that we're not doing very much at the table. I have to still look at but yes, but the gist of it is after week 12, after next week, right after your lab, just go sterilize your XCPs. Thank you for bringing that up. That was a big point that I meant to say. Yeah, well, you should have your initials written on every single one of your little things. And if you don't, then do that this week or sometime with a Sharpie. And then also you should have your color bands on the metal rod and the ring, maybe if you got it on the ring. But on top of that, write it on the bag. So that's like a double, triple insurance. So yeah, write on the bag your name, and that will make sure that you got all the right info down. Okay, so where were we last week? So Monday's group has already done some Caries interpretation, and you guys are seeming to do really good. So I'm imagining Wednesday is going to pick up just the same. I can't remember. How far did I get? Slide 19. Oh, that's right. This one with all the lots of decay in this one. Okay. This is going to be weird because I don't know what my thought process was. So are we just, this is just kind of like examples. So this is just practice really. So we're just looking at the film and then seeing if we can pick out decay. So on tooth number 19, what do you guys see there? Do you see anything that looks like it could be decay on tooth number 19? Say it again.
Thanks, turn down the light.
Yeah, maybe turn down. Thank you. That'd be great. Yeah, I know these. Yeah. So, and then what do you think? Are you thinking that this would be something, an interproximal decay, buccolingual, occlusal? Yeah. And then you can see the shadow comes way down, so that's probably severe or class 4. How about tooth number 14? You can see, it's hard to tell. I know these are never as good as what you'll see in Axiom, but to me, I feel like it comes maybe out to here, which might be a little bit more than half. So it might be moderate, but you know, I never say 100% definitive. You kind of have to pick a camp, and I would probably pick the moderate camp, but I do see that here is where the darkest ends, but then it's a little shadowy further in. So but definitely it's not in the dentin, which is what you really want to notice. And then how about 21? '21 is harder to tell. I think there's an occlusal caries coming in over here. A composite, like up here? Maybe. Yeah, hard to tell. But occlusal. Okay, let's look at this next one. So what about tooth number 13? Class 3, yeah, because it's broken through the enamel. So we see a break in the enamel, and then you can see some shadowing into the dentin. What about tooth number 14? Yeah, it could be a 4. It seems to me like it's less than halfway to the pulp, so I might still say advanced. But who knows really if you saw it on a better image. And then how about 18? Oh, that's occlusal. Yeah, good. Yeah, occlusal and severe. So I think what I'm gonna do just for future reference is anytime it talks about classification or the depth of the decay, I'm just gonna do the terminology and the class. I'm just gonna use both. So incipient is stage 1, moderate stage 2, advanced stage 3, and severe stage 4.
Like advanced and severe.
Yeah, a little back.
So 3 and 4.
3 and 4 is more definitive. Yeah, true. Okay. So here we have some more. We have some interproximal. This gives it away, but we have some interproximal decay. So here we have on the mesial of 13, you can see there's a little bit of a notch here. Distal of 13, little bit of a notch here. Mesial of 14, little bit of a notch. I don't know. I guess I might argue that some of those might be more than one. Yeah, that might be moderate. So I don't know. I'd probably change that. And then distal of 14, you can see class 3. That could also have an argument for class 4 too, I guess, as well. And then on 20, we have some recurrent decay. It's not super obvious because it gets kind of dark down here, but do you see around the base of this filling, you can kind of see some darkness through here. Yeah. And then we also, this pulpal area is darker than the rest of the pulp, which doesn't make a lot of sense. Like, why would this part of the pulp be more radiolucent than down here? And so that's where you get the facial decay from. So there's less structure there. So it makes this like circular part of the pulp look even more translucent or radiolucent.
That'd be like a class 5.
Yeah, I guess it would be. If it's facial, I guess we think cervical for class 5. And so facial technically might be a little higher up more in the middle of the tooth. So I don't know if actually would really be a class 5.
You don't know really
Until you see it. Exactly. Some of this stuff is you just don't see everything that you can do to make a definitive diagnosis until you see it clinically and radiographically. You just have to have both. So here's some more examples. What classification here? We got some shadowing down in here. And here, did I hear class 5? So we got root caries. This is root caries. You can see the CEJ roughly is about here. This is a crown that's been prepped, but the CEJ would roughly be in here. So this is an example of root caries. What do you see down in here? You see some radiolucency. So this is periapical radiolucency or an abscess down here. So, and look how close this decay is to the pulp. So this tooth needs a root canal. Okay, so cervical burnout. So we have some examples of it in the worksheet in lab, or one example, I guess. But so cervical burnout, we didn't actually get to explain what this is. So with the anatomy of a tooth, you know, a lot of the teeth are kidney bean shaped, or the root, we have mesial root depressions or mesial and distal root depressions. You guys have learned about that in McGee's class. And a lot of times, and those are good to know because when you're scaling, you need to turn your toe into those depressions. A lot of times calculus will build up there. So it's really good to know the morphology of the roots. Obviously, it's super important for perio, but it can also help you distinguish between kind of normal, what's sort of normally present, and possible root caries. So cervical burnout is the radiolucent artifact that appears in the area between the top of the alveolar crest and between that and the CEJ. So that little swath of tooth between the CEJ and then, I should have started probably higher than going down, but so starting at the CEJ and then to the top of the alveolar crest, that little band of the tooth, the sides are going to kind of like dip in, and so that area is going to be more radiolucent because there's technically less structure that you're x-raying, radiographing.
What's the cause?
What's the what?
Cause.
The cause of it? It's just like, that's just how our teeth are built. I feel like I'm not answering your question right.
So everyone has.
Yes, but everyone's anatomy is different. So somebody might have maybe more cervical burnout, or certain teeth might have more cervical burnout, and then somebody else might not have as much of natural like root depressions. So it's not necessarily something that you'll see uniformly on everybody.
So it's just like something you're born with, not
yeah. It's just variation in anatomy. And so the cause is literally the shape of the roots, but that's going to vary from person to person. Yeah.
What does it look like if someone like scaled off the root or
like a pretty good ditch. Yeah, you'd see radiolucency. So if someone scaled and scaled and scaled and scaled, and you do see that, like back in the day, hygienists were like, we didn't use our ultrasonics nearly as much as they do now. And so if someone needed a lot of root planing, or you went and saw the same heavy-handed hygienist for 30 years, they could whittle your teeth right down, and it would just make like a thinning in that area over time. But this is actually more just natural anatomy. So if you looked at the tooth would look perfectly normal and perfectly healthy, like in clinically. But on the X-ray, it would look, well, here on the X-ray, you'd see this shadowing right through here, and you know, just all these areas. And notice it's just right between the end of the CEJ and the start of the alveolar crest. So the tooth would look totally normal, totally healthy, no missing structure at all if it's cervical burnout. It's just from that natural dip on the sides of the teeth.
So cervical burnout is normal, it's not caries.
Yes. Cervical burnout is not caries. But people can mistake it for caries if they don't realize what they're looking at.
And that's between all of them.
It could be, although you can see like it's not, you don't really see it here on this premolar, but you see it more on this premolar. So this premolar, A, maybe the angle that they took the X-ray, and B, just the anatomy of that premolar is gonna, it shows up more here than it does here. Same with like, you know, this side to this side. I don't think the anterior is quite as much. We don't have as many dips in our roots on the anterior, more posterior. So cervical caries, the burnout is generally more gradual. You can look for two things. You can look for location. So if you see it specifically at the bottom of the CEJ and between that and the top of the alveolar crest, and then it has this sort of diffuse, kind of gradual little kind of collar, but it doesn't go from one side to the other, just kind of comes in a little bit on either side. Those are big clues that it's just cervical burnout and it's not decay. If it's caries, there's tends to be more of a like a hard edge to it. And you can kind of see like where the caries sort of stops. And that's not always the case perfectly, but in general, you can see where the caries sort of stops. The cervical burnout you notice exactly that it's right between the top of the alveolar crest and the bottom of the CEJ. And so it just sort of comes in here a little bit more gradual. Although this one would throw me. I would probably think that was caries. Well, I know I was going to say, I would actually think that was caries. So maybe it is. I don't know. Maybe this one has a mix. I don't know.
But normally would it be kind of like symmetrical,
But-
like on each side of the tooth?
But I still think no, not necessarily. But I still think because look at the line of the alveolar crest and then the end of the CJ. That's a hard one, but it is a little bit more caries looking. But this one for sure, you can see how it's just kind of like almost like a shadow. You can think of it a little bit like a shadow around the collar. And then if you can frame it in from the CEJ to the alveolar crest, this one, on the other hand, is very clearly caries for a number of reasons. For one, the bone's way down here. So you know that they have recession, you know there's bone, and then there's much more of a very defined notch. So looking for more of a definitive margin and then also location of anatomy. Those will help you differentiate between the two. If there's healthy periodontium, it's likely not root caries. Root caries is far more common when there's periodontal involvement and bone loss.
So like the distal clarity, that's more distal burnout along the margin there,
Yeah.
on the bottom.
Oh, on the bottom.
The distal.
Oh, right here?
Yeah.
Yeah. That's probably more cervical burnout because you can see how it comes in. Although I wouldn't know until I went in clinically. Like if I went in here and was feeling and it felt kind of ditched or maybe it felt a little soft, then I'd be like, no, that's caries. Yeah. But in general, I wouldn't go to Perio and be like cervical burnout. I would probably think if it's a Perio patient, it's higher likelihood that it's caries. Okay. And then like this says, caries does not normally occur if it's a healthy mouth, healthy periodontium. Okay, so rampant caries, you can see that there's multiple areas of decay. This is kind of a very distorted image, lots of foreshortening going on here, but you can still see all of these really dark defined areas. So there's rampant caries. Most oftentimes you're going to see this in kids who, maybe their diet's very bad. They're going to bed with a bottle with juice. They're constantly sipping out of a sippy cup with juice or soda. Good grief. Or what? Yeah, milk too, for sure. But a lot of times it's something even more like, yeah, anything with like, if it's artificial sugars, no, but if it has any kind of real fermentable carbohydrate sugar, then that's going to do it. And it's that constant bathing of their teeth, constant bathing of the teeth in the whatever it is, snacking, but juices usually are liquids are usually the worst. And they just pool around the cervical part of kids' teeth. You also will see this a lot in heavy drug users or older adults because of the decrease in their salivary flow. So if we learn about this next semester, there's gobs and gobs and gobs of medications that cause xerostomia or dry mouth. And so the older population are just at a significantly higher risk for that. Okay, so a couple other things to differentiate. If you notice down here where the red arrows are, you see how this is a very even band. So you might be like, oh, cervical burnout, but look how it connects all the way across. See how it connects from mesial to distal? It goes all the way across and it has this kind of like like line from the top and the bottom. So this is a very telltale sign of a notching or an abrasion. So like toothbrush abrasion, maybe from constant clenching and an abfraction or something from like the constant clenching and grinding or a bad bite or something. And clinically, you can verify this because you'll be looking for it with your eyeballs and you'll be marking it down in your assessment. So you can see the notching at the gum line, and then you'll be able to verify it all. Not verify it, you verify it clinically, but you'll recognize it by looking at the radiograph. Again, here, see how there's this sort of collar that connects from mesial to distal. So you see the whole thing. Yeah.
We're going to exam. Oh, it's gonna be like, are we gonna have like pictures where you give us pictures where you say what it is?
Well, there's interpretation proficiency in lab, and so you have pictures that way. And then as far as the final, you do have pictures, I think, on the final.
Well, what about the quiz on, not the, next Tuesday, the one?
I can't remember what that's on. I'll have to look later.
On the
On the 15th? Yeah, if it's, does it say 23, chapters 23 and 24 or 33? 33 and 34? Then yeah, pictures. But probably some multiple choice too, some terminology and stuff like that. It'll be a mix, I think. If it's over these 2 PowerPoints, it'll be a mix. But pictures, yeah, I will put pictures. Okay, attrition is another one that you will tell very quickly just by looking in somebody's mouth, but you can see how it shows up on a film as well. It just, the top part of the tooth looks like it's been ground away. So they can, because it's exposing dentin, which is softer, and just from the constant washing of just all the different sort of harsh environments in the mouth, a lot of times you'll end up with like little dips or little cavities. In molars, it can be like little circular areas that are just kind of scooped out, and on anterior teeth, it can be through the center here. So you can kind of see how one, either buccal or lingual, is kind of more shallow than the other, and it's more kind of scooped out in the center of the tooth. But you'll verify that, you'll see it right away clinically. And that can be oftentimes from grinding, like just heavy grinders. But food can also kind of exacerbate it if they eat acidic stuff or have GERD, acid reflux, things like that. Here's recurrent caries. So this just sort of as a cross section to show you how if the margins are not sealed really well, it's the bacteria can get in underneath the filling and make its way into the dentin and cause recurrent decay. You can see it down here on this premolar. This is sort of a poor margin, a little bit of an overhang, and there might have been some kind of a little gap, and over time it just, or maybe they didn't get all the decay out to begin with, who knows, but they get this recurrent decay. Sometimes if the restoration is really big, it can block it, and you don't always see this. Sometimes you just have to be lucky and take the right angle and be able to see this on an X-ray. Here are some more examples of recurrent decay and a horrendous overhang. I don't know. I mean, like, that person should never have graduated from dental school. Like, whoever did that is just awful. I remember when I was working for Dr. Matsuda, I won't say his name, and I know it started with an H, but I almost don't even remember it. But I'm not going to think too hard because I don't want to say it by accident. But there was a general dentist that referred to us. He was a wonderful referrer. He referred lots of patients, but oh my goodness, did he have overhangs like crazy on his, and when you saw his patients on the schedule, you just knew they were going to be inundated. I mean, he just did not have a talent for doing good. So it was when he was probably, when I was working for him, I would say I'm sure he was at least in his late 50s, at least, if not. Everyone's gonna try. So this would have been from 2000 to 2005. And it started with an H. Yeah, probably. I'm sure. And it was just really bad. And I just remember you almost feel at some point like an obligation, like I should say something, like don't go back. But at the same time, we're getting referrals from the office. So you want to keep a good relationship. Okay. So so example, what do we have here? Example of bite wings with rest overhang, obviously. Any other caries? This is a very dark film, but you can see some of the areas with caries standing out pretty good. And then you can see here's some cervical burnout. This is some examples of cervical burnout. And again, see how it's between the CEJ and the alveolar crest. And it's just sort of a diffuse shadow. So, and then that almost looks like some abrasion there. So all kinds of fun stuff. Enamel hypoplasia is not necessarily something that you'd pick up. Again, radiographically, you'll see it clinically before you, although really, if you don't do much in a patient's mouth and you take them back and take the x-rays, you might be like, oh, what's that? And then when you bring them back to your chair and start doing your assessments, then you'll see things like the hypoplasia. But you can see it kind of has this sort of radiolucent area through here, kind of, and what it really is sort of a pitted, the enamel's just not nice and uniform and white and pearly and smooth. It's kind of pitted and it might be stained, have a yellowy look to it. So again, it's another one of those things you'll verify clinically. Do you guys see, what do you see in this image here?
Or the band.
The band. Yeah, the abrasion. Yeah, you can see the abrasion here. What about over on this one? This one's a really hard one to look at. Why would I put this one in? It has horrible foreshortening. I don't know why I'm. Unless this is abrasion too, maybe? Like maybe through here? I don't know. I don't like that one anymore. Okay, we're gonna move along. And then how about in this one? Do you see any caries on this film? Yeah, big overhang there. You can see calculus up here, calculus over here, calculus over here.
Yeah, and then, there's something going on.
Yeah, this actually might be root resorption because look how it looks almost like moth eaten throughout here and it's had a root canal. Yeah, but you know how teeth that are teeth that have had root canals can be sort of prone to root resorption, internal and external, and then sometimes it happens and then they do the root canal to try and stop it and it doesn't stop it. That almost is what it looks like to me, but it could just be recurrent decay as well. Who knows? There's a lot of stuff there. And then what about this one? Yeah, it's so horrible. You can't tell, right? Like that's the right answer. This is, yeah, this is like such a bad picture. You can't diagnose anything. Okay, so what else do we have? Beginner's Guide to Radiographic Interpretation. Oh, this is just some more enamel hypoplasia. You can see it, what it looks like clinically, and this is what it can look like radiographically. And then what about down in here? Burnout, yeah. Blurry images. Caries here. Calculus, yeah, there's calculus there, calculus under here, calculus there. Some interproximal. Yeah, good. Okay, so that's it. So you will be, I can't remember if in clinic you guys, you do have to look at the radiograph and you do have to put in things like the filling that you have to fill out an odontogram. And so you are going to be expected to fill out the information. And then I don't know if, I think what the doctor is going to expect from you, and Professor Sarmiento will go over this in a little more detail, but the dentist will, I believe, expect for you to at least put down the areas that you see that are raising a red flag. You're not doing the diagnosis, and they certainly know that that's not even close to where you're at, but they do expect you to write down everything. And they want you to not only look at the radiographs, but they want you to also look inside the mouth. So if the dentist comes over and like you haven't filled out an odontogram and yet you're saying, I'm ready for my exam now, they're going to walk away. And then you're going to have to sit back down and get it all done and then call them back. And 3 other people might have gotten in line before you had a chance to get back and fill it all out. So when it comes to the dentist, it's a long line and you have to sit and wait and usually find other things to do and gather other information. So when you're ready to go up there and sign up for the dentist, make sure that you have done everything in your power to write down everything you see on the radiograph, plus what's inside their mouth, what restorations they have, and not just like a composite, but also like surfaces. So it's a lot that the dentist expects out of you to get all of that stuff in there. And so you want to be able to kind of put that stuff into practice. Okay, so I'm gonna stop this one and then I'm gonna pull up the Perio. Do you guys have any questions on that one?
As far as like questions to expect from that, is it gonna be like cervical burnout or caries? And you're like,
Yeah, I mean, it might be some terminology, but then it also will be pictures too. So I might put a picture and then have you put down the classification. And that can always be tricky because somebody's always, I'll think it's a 3 and somebody will think it's a 4, and then we have to go back and forth. So I really try to pick ones that I think are easier to see if they're just barely into the dentin or more than halfway into the dentin, because otherwise it's just, it's always a sort of a battle. Yeah. Poodle. I just thought of Dr. Seuss book, Fox and Socks, Poodle Battle Bottle, Muddle Fuddle, Duddle. You guys just have to have kids and go find a Dr. Seuss book. It's so funny. I love that. Okay. No, is Dr. Seuss canceled? No. What was it? Oh,
there were ones that people thought were like,
well, it's weird. I mean, Dr. Seuss can be weird, that's for sure. This Fox and Knox or Fox and Socks, it's just a tongue twister.
I just like reading.
Yeah. Okay.
Have you seen I Am Sam?
Yeah. Well, the I Am Sam, that's in the Green Eggs and Ham, right? Or is that a movie?
It's a movie, but he's mentally challenged and he's trying to get to save his daughter. And he loves the book reading and he reads it over and over again.
That does sound, I don't know if I've actually seen that movie, but that does sound familiar now that
Like
you say it.
I-
Oh, I might have seen that before.
with little Danny, the little piece of blonde.
I'll have to look it up after. Okay. Okay, you guys ready? So periodontal disease, put on your listening ears. This will never leave you. And this is like, caries is important. You definitely want to be able to interpret caries, but periodontal disease, you will utilize this knowledge every single day of your dental hygiene career. And you will always pull out your radiographs and your probings, and everything will go together when you're treating a patient. So this is and this is just barely kind of dipping your toe into it. I'll use a couple terms that you'll go far more into detail with McGee next semester, but this is what you need to know to get you kind of off and running for patient care. But you'll probably not put all of this totally together until you start seeing perio patients and your instructors are like, well, why did you decide that they were stage 1? Or why did you decide they were stage 3? And then, well, did you do this or did you do that? Or did you look at your radiographs, or what do you see on the radiograph? You probably won't really put it all together until you get in those situations, but you can always, go back to this PowerPoint next semester, or even senior fall is when you'll really start to see your perio patients. So this is just super, super important information. And similar to Caries, Perio is shades of gray. It's not black and white. The dentist will find out how deep the caries goes when they pick up a handpiece and start drilling. But when you look at it on a radiograph, you're like, looks like this or looks like that. Similar with perio, you can't, like, one clinician will look at something and kind of interpret it maybe one way, and another will interpret it slightly different, because we're talking about percentages that we think it looks like off of a radiograph. So it's not black and white, and everybody kind of tends to have their own, either they're very aggressive at treatment planning or they're more laid back. So just take that with a grain of salt. There's no hard black and white. There are general camps though that we'll live in, and you do need to know those for sure. So as my little intro speech, but now to get into the topic here. So limitations of a radiograph for when we're talking about perio, we're looking at a 2D image. Like we know just from looking at those CBCT scans that have that wonderful 3D dimension, we don't have that in traditional radiographs. It's just a 2D image of a 3-dimensional anatomical structure. So the way we take it matters a lot. So it doesn't show the exact morphology of bone. It doesn't show the nuances of the bone, how it might be lower or buccally or lingually. We just can see that there's generally bone loss there. It doesn't show disease activity. You're just looking at a snapshot in time. So you have somebody come in and sit down in your chair and you see bone loss radiographically. Well, it might not be active. They might not be actively losing bone, but you can tell, like a scar, that they lost bone. You can see that they lost bone at some point anyways. And then it's never a substitute for clinical periodontal assessment, because you have to have your perio charting, you have to look at the gingiva, you have to describe the gingiva, you have to see if there's bleeding, you take systemic factors, and localized factors and all of this into consideration. So it's not a substitute, but it's a tool that you have to have. It's almost incomplete without the radiographs, really. It does not show very early bone loss or early furcation involvement. And I want to stress very early, because it does sort of show early bone loss. Where that line is, it's hard to verbalize, but somebody can start to be losing bone and you may not see it radiographically. And then they hit that line of change or severity where all of a sudden you can start to see it. You start to see like maybe slight moth-eaten appearance, or start to see loss of the lamina dura, or the lamina dura is gone. So it's kind of a hard definitive line, but you can certainly not see it, and it could be happening. It could be starting. Furcation involvement, a lot of times, sometimes if the angle that you take the image might obscure the shadow that you might see in the furcation. So your probe is so important for you to run on a horizontal plane from side to side and see if you dip into a furcation, because have you guys hit that part of tooth anatomy where, like, the trunk, like that space before you get to the furcation? So you have the crown of the tooth, and then you have the space that's like solid, and then you'd have the division into the roots, and how that can be short on people or it can be long on people, right? Does she call it the neck?
That's no, that's what I called it.
I don't know what she calls it but I kind of call it the trunk, but I don't know if that's what but it's that space. So like if somebody has just a little bit of bone loss, you can start to feel the very tippy top of the furcation. And if you run your probe sideways, you can be like, boop, and just, I can just feel a little indent. Yes. Yes, I am recording.
I I think the Zoom password doesn't have it like.
Oh, it's not like announcing, it's recorded. Yes, I did press, thank you for reminding me. And so then, so anyways, I'm going to talk way too much. I have to move faster. But so early involvement of furcation can be hard to tell with radiographs, need your clinical tools. Does not show tooth mobility. You can get a clue if the PDL is really wide all the way around. It's like a pretty good clue. There's probably some mobility there. Benefits of radiographs. So you do see the bony changes when you can compare radiographs. And so there's like multiple snapshots in time. And if they're at the same angle, then that consistency is, you took it at the similar angle. Vertical bite wings are good for that because you're always taking them at a very similar angle. PAs may vary depending on who takes the film. So, and we'll talk more about how that changes the look of it. Tooth and root morphology, you can see to some degree, widening of the PDL, furcations, abscesses, local factors, and pathology. All of that you can see on a radiograph, especially if it's the more bigger, that's a bad word, but the more progressed that it is, then you'll see it even more clearly. Periodontal examination is incomplete with radiographs. So anytime you're doing a root planing, SRP, pull your x-rays up. Always, just have that burned into your brain. So when you go out and practice, you don't start your procedure without the x-rays, because your perio chart and your x-rays will help you so much. So what type of radiograph is best to view bone loss? So here's an example of a very nice parallel. This one was taken with a good parallel technique. Everything is nice and dimensional. There doesn't look like there's distortion. And then here's the same exact area, but you can see how much more distortion there is. You can see the cusps are farther apart here on the premolar, and even on these molars, there's more separation in the cusps. So there's more vertical angulation error. And look where the bone is here and here, and then look where the bone is when it's parallel. See how much less bone, you can see the bone loss when it's parallel. And then of course we always get a nice parallel look when we take our vertical and our horizontal bite wings, because the bite wing is just, when you put it in, it just stays parallel. You don't have to like try to tilt it to fit into the mandible or the palate, or you just set it in there. It doesn't have to go too far up or too far down. And so it's just designed to be a nice parallel technique, easy to take film. And so so a vertical bite wing is a very good idea sometimes when you're just trying to get a nice accurate view of bone level. But you can just see how much variation that is. That's just so obvious. Here's another one, lots and lots of foreshortening. The bone looks far lower, but in reality, when it gets to be a nice parallel image, you can see how it changes so much. This is, I don't know if these are even the same. There's fillings here that this one doesn't have. Oh no, this one, yeah, it is the same image. There's that filling on this tooth. This one's just more anterior. This one's more posterior, but they're the same teeth, or the same side of the mouth, I should say. So that's probably a question. Parallel technique is the appropriate or the most ideal for checking bone level. Radiographic interpretation. So a couple terms we want to know for periodontal disease. Peri means around the tooth. It's the structure. It's all the supporting structure around the teeth. It's a group of diseases that affects the tissue around the tooth. So the periodontal ligaments, connective tissue, bone. The CEJ, or the cemento-enamel junction, right here and here and here. It's the junction between the crown and the root. So it's where the crown stops and the root begins. And then the alveolar crest is the top of the healthy bone that's in between the teeth. And the bone is visible in between teeth on the radiograph. So the alveolar crest, I think the next slide shows it a little bit, it says it here, tends to be more like squared off and flat in your posterior areas, and a little bit more kind of pointy in the anterior areas. In a healthy periodontium, it's the alveolar crest starts about 1.5 to 2 millimeters below the CEJ. So it just varies on everybody. And here's another tricky part with x-rays, is that it can look closer or farther away depending on the angle. So again, bite wings, nice bite wings tend to be a really good measurement for this. I've tried this several times in lab, and it doesn't work because it's not calibrated. So I want to talk to Santoro. Santoro. I just want to say Allison Santoro about how to calibrate it, because you can measure, you can pull up a radiograph and you can measure, you can pull the ruler and put it at the CJ and then put it down to the alveolar crest. But the measurement it's giving you right now is not calibrated. So I don't think it's accurate. I've tried it a couple times and I was like, I don't think that seems quite right. So I'll see about talking to Professor Santoro about that. But so the shape, we already said this, it's more pointy in the front, a little bit more flat in the posterior. The lamina dura, you should see that kind of as a denser area going all the way around the whole root, and then up inside the crest. So we have the crest here, and you should see the lamina dura going around each alveolar crest as well. So one of the telltale signs in the beginning of bone loss is loss of that lamina dura in the very top of the crest. So periodontal ligament space is the other structure, and it should be a very thin radiolucent area all the way around the root. Now, some people, if they clench and grind, they may have a little bit of a widened PDL. I've always had a widened PDL because I clench and grind like crazy. So you may see that even if there's no bone loss. But in general, in a healthy periodontium, it should be pretty close and pretty tight to the root. It should be continuous and uniform all the way around as well. Okay, so when you're evaluating the periodontium, the location and the condition of the alveolar crest is very important. This will be one of the key things for you to think about when you're trying to figure out if somebody's healthy or if they're a stage 1. Because when we get to the stages in a minute here, that's a lot of times can be kind of hard for people to distinguish stage 1, because it can look not that unhealthy really. But if you kind of scrutinize the lamina dura, then you'll start to pick up on those cues. So the lamina dura, is it visible? That's important to ask yourself. Can I see the lamina dura? And then the PDL, is it widened? Yes or no? And then you're going to look at some local factors, overhanging margins on restorations, open contacts where food can get impacted, the presence of calculus or occlusal trauma. So here's an example of a healthy periodontium. And remember, sometimes the x-rays themselves, we lose some quality from the x-rays seeing them this way. So this is going to play a lot. You'll be able to kind of figure this out a little bit more when you're actually looking at stuff on Axiom with your patients, because you'll be able to adjust the light and the dark. But like here, you might look down here and you're like, oh my gosh, that looks like bone loss. And maybe it is, but I doubt it. I think it's just because this part of the film is just dark. It's just kind of a poor quality part of the film to see. But in all the other areas, you can see how you can trace the lamina dura all the way up and over the alveolar crest, and it looks very intact all the way through. The same thing over here on this side, all the way up, and you can see how it gets thinner. It's going to be different thicknesses, wider, thinner, depending on the anatomy. Everybody's going to have a little bit different. And then notice the PDL is also fairly consistent everywhere. Looks like it's wider here. Again, I don't know if that's just from the quality of the film or if it's, something actually localized happening there. I don't really know. So here's obviously where we start to see disease. You can see there's totally loss of the alveolar crest and loss of the lamina dura up around here. It just looks moth-eaten. It looks eroded. There's not a uniformity or kind of a nice flat top. You can start to see a lot of widening here in the furcation. So this is some early furcation involvement, and actually might be like quite significant when you check it out with your probe, even though it doesn't look like a ton on the radiograph, but when you actually put your probe in there, it probably would feel a lot larger. And then you can see that there's all sorts of things like local, there's calculus here And that, I don't know if that might be a little bit of an overhang. And then here it's much more severe. There's tons of bone loss, major open furcation, and then here as well in the maxilla, tons of calculus everywhere. Okay, so here this slide is like packed. McGee is gonna deconstruct this for you next semester and go in, probably more detail, but this is like everything in one big fell swoop, although there's not grading. When you stage periodontal disease, there's staging and grading, and I'm not even getting into grading because it's not really applicable for looking at bone loss on radiographs. It's just too much information, and you'll learn it next semester. But the first thing you will mention is distribution, or it could be also called extent, distribution or extent. And it's just like, is it localized or is it generalized? Is it in one little area or is it everywhere? And basically that's just cut off by a number. If it's less than 30% of sites in the mouth, then it's localized. If it's more than 30%, it's generalized. And you just do that by counting up how many, dividing the areas of pocketing or bone loss by the number of teeth. And so say like I did did I not do it on this one? Yeah, if there's 4 or 5 teeth with pockets, and if they have all 32 teeth in the mouth, then you just divide 5 by 32 and whatever percentage that is. As long as it's less than 30%, it's localized. So it's just a math problem. So when they ask you, is this generalized or localized? And it's the same thing with gingivitis too. And you just basically count up the areas. Is it more or less than 30% of the whole picture of all the teeth that they have in their mouth? So that's distribution. Classification is more complicated, and you'll learn a lot more about this next semester, but they tried to make Perio more in line with how they stage things like cancer. So you've all heard of like stage 1 cancer, stage 2, oh, it's stage 4 cancer, it's like the bad one, right? And so they tried to make that in line with periodontal disease, so it's sort of that integration of medical and dental. So the stages sort of just increase with severity. Used to be we just would say mild, moderate, or severe periodontitis, but now we say stage 1, stage 2, stage 3, stage 4, and then we grade it. And there's a grading that also goes along, grade A, B, or C. So anyway, so stage, and I'll go over this again in another slide, but stage 1 kind of coincides with mild or slight, and it's less than 15% bone loss in the coronal third. So if you take the roots, if you take from the CEJ to the apex and you chunk it into 3 sections, into thirds, then that first coronal third, the section that's closest to the crown, you have to have less than 15% of bone loss in that section. Stage 2 is still in the coronal third, and it would be there. It's basically no more than the coronal third. So between 15 and 33%. And then stage 3 and 4 are anything below the coronal third. So that first third of the root, anything below that is stage 3 or 4. Stage 3 can involve things like vertical bone loss and furcation involvement. And then stage 4 is just like way more, and then just more bad of everything. And then mobility. So sometimes we say 3, 4, like we're just like, they're both bad. But if it's a really severe case, you can say, oh, that's 4 for sure. But sometimes we say 3, 4. Okay, pattern is the bone loss pattern. So there's horizontal bone loss, and then there's vertical bone loss. There's furcation involvement, which we've already touched on. And then there can be ridge defects, which we don't really spend that much time looking at it on radiographs at all, but that can be there. And then severity in general, that's sort of like summarizing the severity. So in general, they have 1 to 2 millimeters of bone loss. This kind of involves CAL, which is clinical attachment loss, which we won't really talk about either too much. But so it's kind of lumping them into how much bone loss, 1 to 2 millimeters, 3 to 4, more than 5.
Does any of this take into account how deep focus are we?
Yes, it does, but also because when you do a periodontal charting, you're measuring from the top of the gingiva till the bottom of the sulcus or the bottom of the periodontal pocket. So there are different numbers that you'll learn. So it does relate to the periodontal pocket, but also you'll have to think about it in terms of clinical attachment loss, because you may have like a really swollen pocket that makes your pocket deep, even though the actual bone loss isn't that bad. Like you may have a pocket that's all swollen gingiva and very little bone loss.
Okay,
Yeah,
so like, you would not base like your stage 1, 2, 3, or 4 off of your measurements?
not alone, but but they do play a role, but not alone. Yeah, you wouldn't, but they do play a significant role, because a lot of times it will directly put them in a stage, but you look at other things too. You kind of look at all of it.
But start with this stuff first.
Mm-hmm. Mm-hmm.
But then if they are getting 6s and 7s more chronically,
Yeah.
even though they don't show like a ton of bone loss, like it's like less than a third, the coronal third,
Yeah,
but
because
they have 6s.
yeah, I see what you're saying. Like somebody who has a ton of pseudo pockets and tons of inflammation but little bone loss. Yeah, you
Like a
would
younger person in the
Mhm.
beginning stages of their
yeah,
life.
you would classify them as lower, but and you'd probably see a lot of resolve in their pockets, because if they had a situation like that, it would be a lot of localized factors like heavy calculus, and get rid of the calculus and the pockets would hopefully go down.
Okay, so be more of a moderate.
Mm-hmm. Yeah. Okay, so here's just another example of the extent. We'll take a break in a minute, I know. So localized, you can see we're just dealing with a few teeth, and then generalized, it's more teeth. So now we're going to talk about the horizontal and the vertical bone loss. So this can be really tricky because you have to pay attention to where the CEJ is. This can really throw some people if you're learning that the vertical just means the bone is sloped. Like if you're thinking, I'll just look for sloped bone. If the bone is straight across, then that'll be horizontal. If the bone is sloped, I'm going to say it's vertical, but it doesn't always work out that well. In general, the bone level, if it matches from one tooth to the next, and there can be like slight variations, obviously, nothing's like perfectly flat, but if it pretty much matches from one side to the other, we call it horizontal. And if it's much less on one side and declines severely on the other, in general, that's vertical. So you can see we have the sloping. So here's the CEJ. So the CEJ is pretty even on these two premolars, but then the bone loss is very uneven between those two premolars. So this is a clear-cut example of vertical bone loss. However, if the CEJ is uneven, which happens a lot, and then the bone loss follows a pattern of the CEJ, that's not cut and dry vertical bone loss, because the teeth are and different planes. And so you kind of have to look, and I'll show you an example of that here. So here's some more examples of horizontal bone loss. This is just saying that alveolar crest should be no more than 2 millimeters. That's for healthy. This is in a healthy mouth. The alveolar crest should not be more than 2 millimeters below the CEJ. Lamina, this is kind of repetitive. I'm not sure why this is here. Lamina dura well defined. Hard to determine whether disease is active or stable. But this is highlighting the horizontal bone loss. It's pretty horizontal all the way through. This is pretty hard to see, but generally speaking, all the way through, it's pretty horizontal. Here's just a mock-up of it, just kind of goes pretty flat. And then vertical bone loss, you're going to see these steep inclines. But notice here how this CEJ and this CEJ are not perfectly even. So this tooth is tilted quite a bit. And so some of that adds to the vertical bone loss appearance. I think this is still vertical bone loss. Like you would still consider it vertical bone loss, but you have to be aware of that when you're looking at two areas. Like if there's a severe difference between, like if the CEJ was way down here and then this CEJ was way up here, then really if you tilted that tooth upright, technically speaking, they'd be at a similar level. So you just have to watch that it really has to be equal CEJs and then the bone level is unequal, if that makes sense.
I'm gonna talk about vertical versus horizontal on like the causes. One, what?
Probably in Perio you will. Yeah, like for bone grafting and things like that. Yeah, I think she'll touch on that stuff in Perio.
So I had,
Mhm.
there is, localized like that and it's vertical, like when it's all together, it'll be vertical.
Yeah, so you could like, I don't remember if that's something that you actually have to document in clinic or not, but you might actually have to say that. So yeah, so if you notice that most everything's horizontal, it'd be like generalized horizontal bone loss with localized vertical bone loss between 29 and 30, furcation involvement on tooth number 31. So you will start to spell out the areas that have something more severe in the localized area, but then generalized. This is what's happening generalized. So this is just touching on CAL, which is clinical attachment loss. And I hesitated to even put this in here because it doesn't really help a lot with like interpreting bone loss on radiographs. I hope it doesn't confuse the matter. But if you're sort of talking about overall severity, slight bone loss, moderate bone loss, severe bone loss, we're talking about millimeters of bone loss from below the healthy normal range of 1.5 to 2 millimeters below the CEJ is like the normal range. So it would be below that range. So if you're in the 1 to 2 or 3 to 4 or more than 5, that's the severity. And that you determine by measuring the CAL. So this was sort of like what Lacey was touching on. So like if you measure a periodontal pocket from the top of the bottom of where the CEJ is down to the bottom of the pocket, you'll get a different number. That's CAL, that's clinical attachment loss. You've lost bone in that area. And then if your periodontal pocket, when your probe, you see that you take a measurement of 7 because that's the top of the gingiva, that's a different number. Not relevant really at all to this class, so don't even worry about it. That's just kind of in there because it's part of the whole grading and staging, but you'll learn more about and be able to kind of differentiate and talk more about that with Mickey. Okay, let's take a 10-minute break and then we'll finish up. And I'm going to hand out some little worksheets for you guys to work on too. So we'll come back in 10 minutes. Can I borrow this handout real quick? This is just for you guys. You probably would do better. Oh my. You probably would do better to take a picture of it if you have like an iPad or something.
My bad.
Oh, I was like, was that the talk cam? Why is it up so close? Why do I get that? So you could just as easily like take a picture of this, and label it. And it's just the labeling. So I would recommend like using different colors, like this band here is the CEJ. So this is just trying to mark the band where the CEJ is. Healthy is just a scotch below the CEJ, just in 1.5 to 2 millimeters. So you can label a note here, healthy 1.5 to 2. And so 15%, less than 15% would be at about this line here. And then we go into 15. I'm sorry, what? I'm talking too fast. I'm sorry. Okay, I'll slow down. There is no key. No, I just thought you could have kind of look at the PowerPoint. I could post a key though. I'll post a key. Yes. Yes. I will post a key so that you guys, but so I would just color them different things. Like here is marking the CEJ.
So the first line, on that, that's in that dash.
That's just marking the area of the CEJ.
So that's the
Yeah, I mean, yeah, roughly this would be your CEJ. And so then you could cut this in half, basically, and you could say, 1.5 to 2 millimeters below the CEJ is healthy. So somewhere in this, just a little tiny bit below the CEJ line is your healthy line. So somewhere in here. And then you have to kind of, now this is the biggest thing I don't like about this, and I should have changed it. This is from last year, but these roots are incredibly short. And so it's hard. So it just, this isn't balanced well. But if you look at the width from the CEJ down to the apex, you basically want to cut it into thirds. So you have your coronal third, and then you have your middle third, and then you have the bottom. And it would make a lot more sense in realistic if the roots were longer. So it's just not it's a little cartoonish. But so then we have our stage 1 is only going to be less than 15% of that coronal third, and then 15 to 33%, which is going to be the cross hatching, is going to be the level of stage 2. So if it goes down below here, then we're into stage 2. I mean, sorry. So the hatching here, anything within this hatching is stage 2. If it goes below this cross hatching, then we're into stage 3 and 4 is what I meant to say. Sorry.
I'm sorry.
I could, maybe what I should have done is like color it. Sorry. You're all like, yeah. Okay. I will color it and I will post a key.
Thank you.
I'm sorry. This is the hard part about when you kind of know, when you've seen something and you're like, oh, this is easy. And then everyone's like, I don't get it. And you're like, wait, what? So I apologize. I don't mean to be speeding through it. So what I'll do is, and the same with this one, this is the Caries. And so I'll do the same thing. So here's what I'll say is try and do it on your own based on the PowerPoint, based on looking at the PowerPoint, or if I get through, I probably don't, what's that?
I just don't get it that much.
If I get through, we have like what, maybe half an hour? Or 25 minutes, if I get through the rest of the PowerPoints, and we'll do this together. Let's do that. We'll do that. And then I will post, either way, I'll post a key for that. And I'll go grab extra ones in my office, so I'm not taking yours. Okay, so we'll just keep moving along here. So periodontal disease, we have, what's this next slide here? And I am recording. Okay, so stage 1, we have this, you can sort of think of, some people may, especially older hygienists, might refer to it as flight. The staging is really new. It's like the last 2-3 years. So staging is not something that's been around for decades. So hygienists that are out in the field that have worked more than 5 years are going to be more accustomed to saying mild, moderate, severe. And there's been enough CE courses and stuff that people are, changing, but it's relatively new. So,
But it's the preferred now.
It is, but insurance, there was a whole thing about insurance recognizing the staging. And so there was like this, in limbo, like, do we teach it? It's not fully embraced yet, but it's getting pretty much embraced by. It's good to kind of think about it in terms of both, but it's more important to learn the staging, because I think the staging is around for the long haul. But don't get confused if someone says mild, moderate, severe. They're basically saying mild, stage 1, moderate, stage 2, severe, 3 and 4 is pretty much what it comes down to.
And then I've heard advanced.
Advanced perio, it might, or also that's probably like tons of vacation, tons of mobility, not responding well to treatment and things like that. Okay, so stage 1 slight bone loss in the coronal third, less than 15% of bone loss. This is an image from the textbook that kind of shows it. You can see it's very little, like you're not dealing with a lot of bone loss. I mean, I know this is just a drawing, but it doesn't always look super duper obvious. Stage 2 is moderate. Coronal third, you're still in the coronal third, 15% to 33% bone loss of the total length of the root. So when we're talking about percent, we're talking about that percentage of the root. The bone loss has gone down to that level. Here's an image from the textbook. And then stage 3, 4, severe, extending beyond the middle third of the tooth. So once we're out of the coronal third, we hit the middle third. And if it goes in, basically you can think about it, if it goes into the middle third, we're at severe. So if we're in that level, visually, when you're in clinic and you look at radiographs, you just have to kind of get used, and this isn't the easiest thing to do, trust me. After being a hygienist for 20 some years, I still am like, So, but you basically have to like look at the root and chunk it up into thirds and just do your best. You're here for 2 years to just make a choice and then talk about it with your faculty and learn from every discussion. It's because, like I said, it's not always black and white.
With our system, our imaging system, can we get a ruler out?
You can, it's just not calibrated is what I've noticed, but I wanted to talk to Santoro about that because a ruler, like that's what's great about the digital imaging is you can measure. So you could be like, oh, is this more than 2 millimeters or is this, blah, blah, blah. And you could actually get some digital radiograph help in the software. So that would be very nice. I would like that if you could do that. We'll have to look into that and see if it's calibrated so you can. And then there's an image. For sure, there will be some furcation involvement, most likely if you're in stage 3 or 4. And everybody knows what I'm talking about when I say furcation involvement, right? The term furcation involvement. So this is sort of just repeated information in sort of different slides. So in a healthy individual, we have well-defined alveolar crest. This is just sort of reviewing it. Within 2 millimeters of the CEJ, we are going to see, this isn't really showing it. It should be, I guess, somewhere over here and here maybe. But you're going to see a nice blocky look in the posterior. You're going to see a nice well-defined lamina dura. Stage 1, you're going to start to see maybe a rounding of the alveolar crest in the posterior, maybe a little bit widening or a tunneling. They call it a tunneling right at the tippy top of the periodontal ligament. So you can kind of see how it's drawn here. Like there's just a little widening right at the top, a little bit of more of a rounding. So this initial widening and initial rounding is sometimes indicative of early bone loss. And so that would be in your stage 1. And that's not that uncommon to see. Rounding of alveolar crest, loss of defined lamina dura. If you can see a really defined lamina dura and you think you see a little widening of the PDL, it might not be bone loss. So we can't always say definitively 100%, well, I see that there, so that's bone loss. Like we just can't, because if you take them into consideration and their gum tissue is stippled and pink and tight and shiny, and like just looks beautiful, and you probe and there's no bleeding and the lamina dura is there, but you do see a widening. You can't be like, well, I see that widening, it's bone loss. You know what I mean? Like you just have to kind of take everything into consideration a little bit. So sometimes it could be some other factor, likely perhaps maybe they clench and grind a lot. So that, yeah.
During like ortho, can you have like a widening?
Yes, definitely. Ortho. Because you're moving stuff around, right? You're messing with the PDL and the bone and everything. So yeah, for sure. And ortho, you can have all kinds of funny things happening, but. Okay, so stage 1, again, eroded alveolar crest, more than 2 millimeters from the CEJ, less than 15% of bone loss. Stage 2, moderate, 15 to 33. It's talking about Cal again, that severity, the clinical attachment loss is just added into this slide. 3 to 4 millimeters of total clinical attachment loss. Clinically, you can measure out with the probe that they have 3 to 4 millimeters of clinical attachment loss. That's what it means. Stage 3 to 4, severe or advanced. There's bone loss, probably vertical and horizontal, and some furcation involvement, especially as we get closer to the 4s for sure, and then mobility, and it's extending into the middle third of the root. So that's all just kind of repetitive. So here's an example of horizontal bone loss throughout. Definitely severe, major furcation involvement there. And that's really easy to see. Like more severe perio is easy to see. The difference between 1 and 2 can be a little bit harder, and sometimes even 2 and 3. Like you can hem and haw with faculty. I hear, it goes on all the time. Like, well, you put 2, but I would really put 3. Here's another tip that will come back. You don't have to memorize this today, but you'll learn it next semester and it'll come back in clinic. The area of the most severity is the stage. So if somebody has 1 molar with 1/5 and it happens to have furcation involvement and everything else is pretty normal, they're staged at that tooth. So they would, they'd be a stage 3 because of that tooth. So if they have 5 millimeters of clinical attachment loss and furcation on that 1 tooth, then that's their stage. So you can write up a narrative that says generalized healthy stage 1, or generalized healthy periodontium or whatever, localized stage 2. But when you stage them, like officially, you have to stage them at the higher, which seems kind of weird, but that's how they do it.
Is this only in stage of like disease, or like when they're controlled periodontal disease and I still have this much bone loss, is they're not gonna go back together? They're
Yeah.
always that stage,
Mhm.
even if they're on their maintenance.
Yeah, that's a good point. A good, even if they're stable, they're still staged. It gets a little confusing, and I don't even want to go there, but there is like healthy on a reduced periodontium, but the criteria are very specific, and it has to fall in line. So generally speaking, somebody can be at a healthy, stable stage, but perio is a lot like diabetes. It's like you stabilize your diabetes, but you very oftentimes, I suppose some people maybe can reverse type 2 diabetes, but in general, it's maintained by good life. You're always prone to it. Lifestyle can help. Maybe you can get off the meds, but in general, you're always prone to it. And perio's the same way. If you have active periodontal disease, you're really always prone to it. So you have to be very careful. And so you're always, you stay at the stage because you lose that bone level.
But then you would just like control.
Yes, like stable. And you can put your, gingiva is healthy and firm. There's no bleeding upon probing, but there's still all this evidence of periodontal disease. So here's just another like example of the CEJ. So the CEJ is even here and the bone level is even here. So that's just highlighting the horizontal bone loss. Oopsie doopsies. Back it up. Okay. Radiographic interpretation. So increased complexity, you can see a big widening of the PDL through here and all the way around down here. Lots of furcation involvement, huge furcation involvement. When we see that, we can you have to check mobility on every tooth when you're doing your clinical assessments. But when you see the widening of the PDL, you sort of assume there's probably some mobility. And so you just double check. If you've gone through and checked mobility really fast, slow down and check those ones that you see on the radiograph. Go, oh, there's awful lot of widening. I better check that mobility again. Yeah. It is furcation, but it's really both, but it's furcation. At this stage, that's furcation involvement. So and you can verify that clinically with your probe. Like if you can go in and feel that dip, then you'll verify it that way. But yeah, I would say that it's probably more than just a widened PDL. It's some bone loss there.
Would you label that as positive furcation?
It's hard to tell until you get in there, but yeah, if you are just barely feeling just barely feel a dip, it's class 1. And if you feel like you're getting into it at all, then it's class 2. I think it's harder to say on a radiograph, but sometimes you, like this one, you're like, well, that's through and through. I mean, my goodness, if that's not through and through, I don't know what is, but it's a little harder to say furcation classes just by radiographs. Again, just some furcation involvement. There's caries on this one. This is just showing different examples. Notice how you see the lamina dura here, but there's no lamina dura interproximal here. It's all, you don't hardly see any lamina dura anywhere on these. They're also kind of lighter films as well. And then just also noting some of the bone level too, like seeing how this bone level kind of comes down at quite a slant there. But this one looks a little slanted as well. But these CEJs might be off. Like this CEJ is here, and then this CEJ seems like it would naturally be here. So I still feel like that's actually more horizontal bone loss, even though it kind of looks tilted. So sometimes it can be a little tricky that way. Oh my goodness, sorry. And then this is again showing just the level of the CEJ and then the level of the bone to describe the bone loss as horizontal for those not vertical. Yeah.
For slide 24,
Yes.
the top picture for the first and second molar, is that horizontal or vertical?
This one between here and here, because the CEJ, there's decay here, but the CEJ is here, and the bone loss kind of goes the opposite. So this to me looks like there's some vertical bone loss either in the facial or the lingual, because you can see sort of a faint. That's probably, so remember you're looking through a plane of buccal and lingual. So there might be vertical bone loss on either the front or the back, and then the other side, and then it might scoop through and then be more. So it's the actual real anatomy of the bone loss can be tricky, but to me, it looks like there's some vertical there. So yeah, I wouldn't test you on a film like that because that's a little bit not clear cut enough, but yes, I do think that there is some vertical bone loss there. So some other predisposing, is that what I meant to say? Precipitating, predisposing, I guess that works. Predisposing factors or local irritants. So we would think of calculus, defective restorations. So you can see all of these pretty atrociously prepped crown and overhang restoration. It's so critical to be a dentist when you're not one. It's like, oh, I would never do that, but who knows? I mean, it's not an easy skill set. It takes a lot of work. But and a little overhang here, open margin here. Tons of calculus. You see all of these rings of calculus around the anterior teeth. Don't forget when you're scale the linguals of your maxillary anteriors. People forget that area all that time. And there's lots of calculus that can form there, especially over time if you kind of don't do a lot of scaling there, and then you get up in there and actually, because it's kind of harder to reach that area. So sometimes we don't spend as much time there as we should. But rings of calculus there. Huge overhangs. I mean, you can just see all of these major overhangs here and here. Lots and lots of calculus. This is darker. It's harder to see, but there's calculus here and here. Always, when you take your films in clinic, take your films and look at them and mark calculus. If you see, when you guys are trying to figure out light, moderate, heavy calculus, if you see it radiographically, it's moderate. Just go with moderate. Don't worry about feeling it and being like, weh, weh. You still want to go back and feel it because you want to feel what it feels like, with your Explorer. But if you see it on the distal of 12, mark distal of 12M, moderate. Just, that makes your life a little bit easier. And then you can go in and hem and haw about the other areas that you don't see it radiographically, but you'll feel it clinically. So, okay, so what do you guys see here? Vertical boneless. Yeah, it looks vertical. It could be a little illusionary just because we're on the corner, but it does look vertical for sure in that picture. So vertical bone loss, horizontal, tons of calculus. Just guessing, what would you put this for a stage?
Forward.
Yeah, three or four for sure. It's harder to, you're kind of, there's no furcation involvements in the anterior, but it's a huge amount of bone loss. So I'd lean toward a 4 as well. What do you see on this one? Calculus, horizontal bone loss.
Vertical also.
This one I probably wouldn't, I mean, the shape of it is, nuanced, but I probably would still roughly call it all just horizontal bone loss. Oh, here? Yeah, I would call that a horizontal, even though it dips slightly, I would still call it horizontal. Why?
Yeah, just because I can't tell the difference.
It would be like so think of one slope either going higher on one side and lower to the other, or vice versa. So if it just slopes, like dips a little in the center of the bone, that's still roughly horizontal. So, but if it's like tall on, 11 and way down here on 12, then that's vertical.
Okay.
Yeah. And then what do you see over here on this one? What did you say?
Wouldn't it be bone loss in the second molar?
Oh, bone loss here. Yeah, a little tiny bit. Or I'm trying to think, is this a healthy one? Is this healthy? This might be a trick, because here we can, you can see, I know that you see a little roughness here in the bone, so that's probably triggering you to think a little bone loss. Which it could be. I mean, it could be absolutely the itsy bitsy beginnings of it, kind of a moth-eaten appearance, but you do sort of see a fairly good intact lamina dura, although I guess you could argue it looks a little less intact through there. And that's what it is. Thank you very much. I was like, why did I put this picture in here? But that's good to look at the bone level and try to critique it. That's very good. But this is what the main objective is there's an open contact here. And so those areas that constantly get food impacted will just over time tend to have problems and tends to get wider and wider. And so they're just more vulnerable. Here on this side, we can see we got some bone loss started there, localized factors, calculus. You guys all can see the calculus pretty easy, huh? Anyone having any trouble at all? Like once you see it, you can't unsee it. It's like, I just see calculus everywhere. It gets exciting. Okay. What do you see here? Calculus, calculus, calculus. What about this? What would you think of for the type of bone loss? Horizontal, yeah. This is tipped a little bit, but you can see the CEJ is roughly still the similar, and it's hard to tell because this has a crown, so you really lose the natural CEJ. But in general, like I wouldn't try to be tricky. I'd call it horizontal too. I wouldn't try to trick you. Do you see any furcation involvement?
Yeah.
Starting to see some shadowing there, so some furcation involvement. So this one, it's a really poorly contoured stainless steel crown, and it's been in there a long time, and you can see they did a pulpotomy or whatever they did on this tooth, and it's just degraded the bone all the way around there. Plus there's probably some periapical abscess. It's probably perio/endo, really. And then over here, this is super blurry, but you see overhangs and calculus. There's decay. This is a large decay, even though this image is pretty blurry. Oh, what was it? Yeah, that's hard. That kind of thing, like if it was a huge chip, then that's the same thing as like erosion and attrition and stuff like that. You have to use your clinical and your radiographs to help answer those. But yeah, it could be like a big old chunk. Yeah. Oh, sorry. Yes, I would call all of this one here, I'd say vertical, but everything else I would call horizontal bone loss.
So, didn't you say that it was a dip? Horizontal, and it is that a bit
Well, this is a unique situation because the bone literally goes all the way around the apex of the tooth. But if the bone, like, let's just say the bone loss stops here, then you're talking about it's at this level on this side of the tooth and it's gone down to this side. But it still would be considered, I wouldn't test you and throw that in a test because that's a little tricky. I see what you're saying, but it's always comparing one tooth to another. And is it higher on one side and lower on the other tooth? Yeah. So this one, obviously there's tons of calculus here, tons and tons of bone loss. This tooth is probably gonna be mobile once you break the calculus ridge. So here is what it looks like clinically, and there's like a bridge or all the teeth are basically stabilized by that calculus, but the minute you take it all off, you're gonna have some major mobility. So you guys will see stuff like this in your lifetime. So here's a kind of I guess this one's kind of trying to be a little bit sneaky, but what kind of bone loss? Horizontal, good. And then do you guys see how light this little shadowing is here? That's a great image of something you might feel clinically, but it's actually a little bit of bone loss started in, but you can really verify it with clinical. So I'm going to just fly through these. There's answers in the notes that you can see, but because we're pretty much out of time. And I'll do those worksheets and I'll post the key, but just try and look at these worksheets and compare them to the schematics in the PowerPoint. And I do think you'll be able to, for the most part, answer these, and then I'll just post the keys though in this week. But these are just examples for you to describe the bone loss. This is healthy. Notice all of the nice lamina dura. There's the answers are in the notes if you are questioning, but these are healthy examples. That's vertical. Saba, this is a really good vertical here. Even though the CEJs are uneven, this is still steeper, so it's still vertical. And that's just looking at the difference again of the. Okay, that's it. Sorry, you guys, that's so much material, my word.